Good morning, good evening, good afternoon, wherever you are. Welcome to another intensivecarehotline.com live stream. Today's topic is 10 proven strategies to counteract pressure to withdraw treatment in ICU without patient or family consent. This is one of my favorite topics. It is a topic where we give a lot of advice, where we helped a lot of clients and their families, and where I can say without any hint of exaggeration that with our strategies and advice we have saved some lives without the shadow of a doubt. And you can verify that by looking at our testimonial section at intensivecarehotline.com. You can look at that and verify that on our podcast section at intensivecarehotline.com. We've done some client interviews. Before I go into today's topic and break down the 10 proven strategies to counteract withdrawal of treatment in ICU without patient or family consent, you may wonder what makes me qualified to talk about today's topic. I'm a critical care nurse by background, and I have worked in critical care for nearly 25 years in 3 different countries. I have worked in as a nurse unit manager in intensive care for over 5 years. I have been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And once again, I can say without a hint of exaggeration that we have saved lives over and over again for our clients with our advice, with our consulting and advocacy. And we are highly specialized on patient rights and family rights in intensive care. I'm also the founder and managing director of Intensive Care at Home, where we send critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomy. With Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in regional and rural areas. And there as well, we are heavily involved in the advocacy for our clients. We have saved lives by taking clients home from intensive care. Another aspect of this topic today is also that sometimes, patients are inevitably going to die. However, what's also an aspect of this is having an end-of-life situation on your terms, right? Very important for peace of mind. Very important that you have a say, or your loved one has a say, how they're going to die. Do you want to die in intensive care, or do you want to die at home with Intensive Care at Home? And by the way, you can find more information about Intensive Care at Home at intensivecareathome.com. Without further ado, let's get into today's topic, and let's go through the 10 proven strategies to counteract withdrawal of treatment situations in ICU without patient or family consent. And I actually want to start with a couple of case studies that we produced over the years, so to illustrate the landscape that is intensive care, and you will see how difficult it can be. I want to start actually with my time in ICU when I still worked at the bedside in ICU, and there was a situation I remember when I came onto a night shift for a patient that was inevitably dying. There was no question around it, no concerns around it. However, the way the ICU went about it, put me in an advocacy position. I was told on a night shift, well, at 10 o'clock tonight, you are going to stop the ventilator and you're going to take the breathing tube out because we are going to, quote unquote, palliate this patient. And my gut instinct was, well, the family is not ready for that. right? Have you spoken to the family? Oh no, we haven't spoken to the family yet. We're just going ahead with it. And that felt me like I was in an execution situation. I'm a critical care nurse, not an executioner, right? So the doctor told me on shift, "Do you mean you are refusing my orders?" And I said to him, "That's exactly what I'm doing." Make no mistake. And after a lot of back and forth, I spoke to the family. That was the plan. The doctors and the nurse in charge didn't like it, but I certainly wasn't budging. Cutting a long story short, the whole process was delayed by a few days. The family was still waiting for a family to come in from overseas to say their goodbyes. I know how ICUs operate. I've worked in this field long enough to know how ruthless they can be. Don't get me wrong, there's a lot of good things happening in ICU, but unfortunately, that's not our topic today. Today, we're talking about the pain point that families are experiencing in intensive care about withdrawal of treatment situation where there's no bilateral agreement. It's a new unilateral decision which never works, right? So that was sort of one of the situations that I experienced in ICU. There have been many others, don't get me wrong, but that was one of these situations that I vividly remember that also triggered me to start doing what I'm doing now, where I just thought, no, this is not right. Families need to know about this, what's happening in ICU, how ICUs operate, because the next day they needed a bed. They had long surgical lists lined up, where patients needed ICU beds. And it's a fight for resources, unfortunately, for limited resources. But ICUs must find better ways, which includes treating the staff better, whether it's doctors and nurses, to retain them there, so that there's more capacity to be created. It also comes down to using services like intensive care at home to free up ICU beds. It can't be the way forward to withdraw treatment without family or patient consent to free up beds. That can't be the way. That is not why we are working in this environment, to take shortcuts, right? Anyway, so other examples that I can give you then working with intensivecarehotline.com are, I remember having had numerous phone calls over the years, and I remember three of them very vividly. One gentleman calls me one day and he says, "Look, my dad's in ICU. He's had a stroke, he's on a ventilator, he's got a breathing tube. Tomorrow at 3 o'clock, ICU said they will withdraw life support and he's going to die because he's not going to survive and he won't have any quality of life anyway if he is going to survive." And I said to him, "Look, here are my fees, but I'll promise you, if I can't save your dad's life, that you will get your money back anyway." I don't know why I said it. I said it anyway, and lo and behold, I did save his dad's life because I spoke to the doctors and the nurses at the time, and I said, "Look, are you aware of this patient and family rights? And here are the laws, and here is the legislation. And what about your hospital policies?" And lo and behold, they backed off. And his dad lived for a very long time after that, right? So you also have to question the judgment of doctors and nurses sometimes. Is that judgment just a plot to free up their ICU beds to get their way? Because the reality is, if they're telling you, well, your loved one is not going to survive anyway, and how many times have I seen, oh, your loved one's not going to make it for the next 24 hours, and then they do, you have to question their clinical judgment. And any minute that your loved one survives strengthens your narrative, which is you want hope, you want survival, you want good outcomes, most of the time anyway. And every minute their judgment is off, it strengthens your case. Another example was with a local client here in Melbourne, in Australia. Again, similar phone call, tomorrow, they want to withdraw life support on my dad. In this instance, I was able to visit the patient in ICU and looking at medical records, which is, by the way, something I highly recommend to you. No matter where you are at in your journey, get access to the medical records so you can get a second opinion. You can get familiar with what's in there. It'll help you to ask questions. Highly recommend you get access to the medical records, because in that instance, in that second example that I'm going to give you, I looked at medical records and I immediately saw there was foul play in terms of that the patient had been issued with a DNR, a do not resuscitate order, and an NFR, a not for resuscitation order, without, once again, without patient and family consent, without the knowledge that this order even existed. So we took that to court. Don't get me wrong, I am not a lawyer. We engaged a lawyer. And that was enough to have the decision of the ICU team to withdraw treatment prematurely without patient or family consent overturned, right? So please keep one thing in mind here. ICUs or hospitals in general are incredibly good at pretending they can do whatever they want. Right? Don't be misled by that. Don't be fooled by that. Right? End of life decision making, medical decisions, they do not happen in a vacuum. They do not. So let's just take a simple example. You go to your dentist for a regular checkup. Well, your dentist can't do anything on you without having your consent. Let's say you go to your GP or to your family doctor, just for a quick checkup, and, they're looking in the back of your throat, or they're listening to your chest with a stethoscope, take your blood pressure. Nothing of that can happen without your consent. Now, do you think that withdrawing life support can happen without your or your loved one's consent? Think about that. How can hospitals have the audacity to say, we're going to withdraw life support tomorrow at 3 o'clock and your loved one's going to die, without any checks and balances? And how many families have I seen just roll over and say, oh yeah, okay, if that's what you think, well, that's what we'll do. You must know best. Well, what they do know best is that they need the ICU bed the next day. Right? What they do know best is that not withdrawing treatment could present their worst case scenario. What's the worst case scenario for an ICU? Well, the worst case scenario for an ICU is to look after someone indefinitely with an uncertain outcome, because that's what many of those situations present for them, right? So don't be fooled that end-of-life decision-making, medical decision-making is happening in a vacuum without anyone needing to give consent. Another example that I can give you is, again, worked with a client, similar situation, was on a weekend, I remember that, and we rang up the Supreme Court on that day, and the Supreme Court put in an injunction within an hour, right? So don't think that you don't have any rights or that you don't have any power here, but you have to take action, right? And it doesn't matter which jurisdiction. I mean, I'm in Melbourne, Australia, but we've helped clients all over the world, whether it's in the UK, US, Canada, Australia, doesn't matter. There's not one jurisdiction where you don't have the right to object to having a loved one killed, right? So think about that. Okay, also in the meantime, if you have any questions around the topic, please type them into the chat pad. Please keep them to today's topic. I will hopefully have time to answer questions later as well about other questions in intensive care, but for now, please keep your questions on the topic. So now let's look at the 10 proven strategies. Well, the first strategy is that you need to ask for the end-of-life care or withdrawal of treatment policy in the ICU. That is the very first thing you need to do. That's how sort of I, for lack of a better term, stumbled on this. When I still worked in ICU at the bedside, I was in those situations. I was just, hang on a second, can they just do that? Then I looked at end-of-life care policies in ICU, and clearly it said patient and family consent, right? And then it went to the next level. So that's one proven strategy, to ask for hospital policy about patient and family consent when it comes to end-of-life decision-making. If they're not giving you the policy, you already know what's in there. If there's a delay in giving you the policy, you already know what's in there. What is it that you can't see? Right? That is your first point of that's your first point of contact, really, when it comes to those situations. Next, you have to look at your local laws around end-of-life care decision-making. And once again, you will find in those laws, again, whether it's in the US, in the UK, Canada, Australia, New Zealand, the law will say there needs to be consent, right? I can't stress this enough, that end-of-life care decision-making does not happen in a vacuum. It happens around checks and balances. Next, family meetings is another proven strategy. So often you'll be advised or you'll be told to go to a family meeting with intensive care teams. Well, I would not go into a family meeting with intensive care teams unless you have an agenda in writing. I still can't believe how many families in intensive care get told, oh, can you come to a family meeting tomorrow? 9 times out of 10 it is to give you bad news. Families in intensive care don't know what they don't know. It's their biggest challenge, as a matter of fact. They don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. That's your biggest challenge. So when it comes to family meetings with intensive care teams, don't fall all over yourself if they tell you, oh, tomorrow at 2 o'clock we are going to have a family meeting. Well, if they say jump, you don't ask how high. Do not do that. Your next response to a request for a family meeting is to ask for an agenda in writing. Now think about this. Any meeting in life, business meetings, has an agenda. So you're going into a meeting about life or death and you're not asking for an agenda. Think about the lunacy of that. Right? Be strategic, be logical. Be logical. Don't be carried away by emotion, because I'm well aware that these situations are highly emotionally charged. There's no question about that. Don't be carried away by emotion. Stay logical, stay strategic, right? And ask for an agenda in writing. Common sense, which is not all that common anymore. It is common sense to ask for an agenda in writing when it comes to family meetings in intensive care, when it comes to medical treatment, when it comes to potentially life or death situations. How can you not ask for an agenda in writing? And once you've got the agenda in writing, then you can think about whether you want to add something to the agenda that's of your liking, whether you want to subtract something from the agenda, things you don't want to talk about, and then you decide whether you want to go to the meeting or not. This is your decision, right? It's not their decision. Don't do what other people do. Don't do what 99% of the people in intensive care do. Do what the 1% do. Only then will you get better outcomes. Next. Get access to medical records, right? As soon as possible. Get access to medical records as soon as possible so that you can get a second opinion as soon as possible. Now, I've been talking about this for many years. There is a difference in intensive care about real end-of-life situation versus perceived end-of-life situations. What's the difference? The difference is that a real end-of-life situation is that no amount of treatment, surgery, medications will save your loved one's life. That's a real end-of-life situation. A perceived end-of-life situation is that there's a perception that it is an end-of-life situation. Well, perception doesn't equal reality. Often, very often. What is your perception? Right? And what does the intensive care team need to do to change that perception? To make it more positive, to give you hope, to do whatever it takes. Right? Okay, so and then once you have access to the medical records and you have a professional like us review them, then you can go back to the intensive care team and challenge them and say, hey, we've had a second opinion. Here's what we are finding. Right? Getting access to medical records is critical. Absolutely critical. And then having a professional review them is even more critical, like we do here at intensivecarehotline.com. Next, you need to have an advocate like myself ask the right questions. So I started this call with real-world examples, and you can see that the only way we saved lives is by asking the right questions. We know what to look for. We know what questions to ask. We know the weak links that intensive care teams have in terms of where they, we know that there's only shaky ground when they want to withdraw life support without your consent or without your loved one's consent. There's only shaky ground. There's no solid ground there. Keep that in mind. Right? Next, refer back to case studies. Right? There are so many case studies on our website. There's an interview on our podcast with one of our clients where we had a very similar situation. They wanted to withdraw treatment because the ICU said, well, this person won't have any quality of life. Now, I couldn't have asked for a better case study. Have a look on our website, intensivecarehotline.com, on the podcast section. There is actually a video interview with a client who was a patient in ICU about 18 months ago, maybe 2 years ago now, who was told, well, he won't have any quality of life if he survives. He's sitting on an interview talking to me, saying he does have quality of life, and he did survive, right? So take that case study. I can tell you exactly the name of the case study so that you can find it. So go to intensivecarehotline.com, go to the podcast section, and go to the podcast section and click on the podcast. I'll tell you in 1 second. My apologies. But I think it is important, very important, that you watch this podcast. Go to the podcast. Thank you for your consulting and advocacy service at Intensive Care Hotline. You are a light of guidance to people and you saved my life. This is from the 16th of May, 2023. Go and watch that podcast. This is having a family and a patient on the podcast who was told he's going to die and we should just withdraw treatment. And this man is sitting on a podcast talking to me and his family, sharing his story. Next, going in line with getting the medical records, get a second opinion. Right? Get a second opinion, always. But get a second opinion that is not attached to the hospital. Get a second opinion from someone that is really independent. Right? Don't get a second opinion from someone who's mates with, potentially the doctors or nurses there. Next proven strategy, get a hospital transfer. Go to a hospital that is more aligned with your values. For example, we were working with a client, not in the too recent past, who has their loved one in a, local hospital, and, they want to stop treating their loved one. And then the client was looking around town and seeing what other hospitals are there. So then they found a Christian hospital around town. And the Christian hospital has values that are aligned with our clients' values. And the values are, well, we treat anyone and everyone here. It's not dependent on anything, whether we treat them or not, because we treat all human beings. It's probably more aligned with what some ICUs are doing in this day and age. Right? And I can say that this hospital, I want to name that, it's the Mercy Hospital in St. Louis in Missouri in the US. They seem to have very good values, and those values certainly align with our values, and those values align with our clients' values. That's probably another thing you should be doing as a side note. you should be closely looking if the values the hospital is displaying are aligned with your values. And when it comes to values, I wouldn't necessarily look on what's documented on a website. I would actually look at what they're doing on a day-by-day basis. I watch what people do, not what they say. As a matter of fact, I'm not really interested in what people are saying. I'm interested in what they're doing, right? Because actions speak louder than words. Next, get a lawyer, get an attorney. That's a last resort. We have saved many families' lives without a lawyer involved, but we have also saved lives with a lawyer being involved. So, it's a last resort. Sometimes it is enough for you to say, if X, Y, and Z are not changing, we will get a lawyer involved. And that is often enough for things to change, because hospitals don't want to deal with legal teams. They generally speaking don't. So don't underestimate your power. Don't underestimate your power that you have in these situations just by you putting the pressure on. And number 10, go to court. Like I said, I remember one situation very vividly. It was actually on a Sunday, and we had a similar situation. And at the time, quite frankly, it came out of sheer desperation. I just thought, well, let's ring the Supreme Court and see what they say. On a Sunday, they had an after-hours number. Within an hour after we explained the situation to them, they issued an injunction to the hospital, right? And they could no longer do what they wanted to do. They had to act in a patient's interest. Can't stress enough that end-of-life decision-making does not happen in a vacuum. It happens around laws, policies, procedures. It happens around ethics. Now, so these are the 10 proven strategies to counteract pressure to withdraw treatment in ICU without patient or family consent, and they have always worked. I tell you what hasn't worked. What hasn't worked is people not taking instructions from us. That's not working. If you think you can, run your own ship when it comes to these situations, you are on the wrong track. People who can't take instructions from people who have walked that path before many, many times, you will not succeed. I haven't seen it. I have seen people failing because they didn't take advice. I have seen people dying because families didn't want to take advice. And I have seen people failing and giving in and losing their loved one's life if they're not questioning. So that is a word of warning. Now, because you're still sticking with me, I also want to give you 3 bonus tips, right? And thanks for sticking with me so far. I want to give you 3 bonus tips. The next bonus tip is to make a complaint to hospital executive, right? Make a complaint to hospital executive and you will see the world is changing. Now, Albert Einstein famously said, you cannot solve a problem on the level that it was created on. What do I mean by that? So this problem is created in ICU predominantly, and you won't solve this problem in ICU most of the time. I mean, I've already shown you, what you need to do, and most of it is outside of ICU, looking at medical records, getting a second opinion, look at case studies. None of it is really in ICU. And you'd be surprised a hospital executive cannot ignore the complaint of a patient, not let alone when it comes to end of life, right? So go and make a complaint to hospital executive. Next, try to escalate it to the ethics committee in the hospital. Now, a word of warning here. You would have seen me make videos about ethics committees in the past. I don't have a lot of trust and faith in ethics committees. I really don't. I think if anything, they will be the advocates for end-of-life decision-making in favor of the hospital. I refer to the ethics committee as hospital employees, and they will not go against their own employer. right? I will go as far as that in some instances I have seen ethics committee being highly unethical, going along with hospitals to get along. Once again, where's the third party oversight with ethics committees? You know, if they're hospital employees, there's no third party oversight. But it is worth for you pursuing. There are some cases where the ethics committee has actually been ethical and has been acting, you know, in favor of a patient and the family, right? So it can be a strategy that can work. And lastly, my last bonus tip is that, you know, you should start, if you think this is really not going in the right direction, you start using stronger language. You start using stronger language by starting to talk about, you know, murder or potential euthanasia. Both murder and euthanasia are illegal. They are crimes. That is also often something that can work and gets them on the back burner because they're realizing how wrong their behavior is. So I hope that sums up the 10 proven strategies to counteract pressure to withdraw treatment in ICU without patient or family consent. I encourage you to ask questions if you have any. You are welcome to join me live on the show here now. If you have questions in regards to today's topic, type them into the chat pad or simply join me here on the StreamYard link and you can talk to me directly. Maybe you have your own experience. You know, I would welcome any story that can be shared, good or bad. You know, if it's good, that's great. We can learn from it and there's more encouragement. If it's a bad story, we still want to know about it because, again, people can learn from it as well. Now, while I'm waiting for your questions, I just want to go to Leo's question. Hi, Leo. Good to see you again. You are saying, my father was kicked out of ICU because he was off the ventilator for 30 hours now, and they want to kick to the local LTAC again. I'm at my wit's end. Okay. I remember talking to you, I think, last week, Leo. Have you made the complaint to hospital executive? Have you written to them? Have you done that? Right? Because that's where I left you with from memory. Last time I spoke to you here, that's where I left you with. And with what you've shared here so far, that would still be my strategy. Next, while I'm waiting for your questions or comments, I will now answer questions here that have come in during the week. But I would welcome any questions you have here, or join me on the StreamYard link and ask your questions there. Let me go to the questions here. Hi, Patrick. My baby brother is in ICU and he has been in a coma since the day after Christmas. They had him at another hospital 2 hours away. The hospital was trying to push us to remove his ventilation and let him go. The doctor had told us he was unresponsive, wasn't awake often, and that he was brain dead. They said, in quotes, no activity. He wasn't breathing. We didn't want to talk about brain dead, so we declined the topic. He was moved back to the hospital locally 3 days ago. We went to speak to the care team and he was awake. He was tracking movements with eyes and would look to sounds. Now, with that being said, he wasn't able to respond to commands, but it was his first day awake almost all day. He does jerk his feet away if you touch his toes or try to tickle him. He will hold eye contact for short periods of time, then wander off from it. I believe he has tried to acknowledge a statement once, but I'm sounding horn to a very impactful statement from his oldest son. Also, we put his stepmom on the phone for him to hear. Again, I'm not sure if this was another perfect time, not if a weird neurological response, but he had a face of upset and he wanted to cry. Then a single tear rolled down one cheek. When I went to wipe the tear away, he reacted with his eyes as if he knew I was moving my hand close by. He responds to touch, rubbing of the head and belly. Like a baby does his eyes roll like it feels good. So I'm not sure what is what. He overdosed and was laying there a long time. He does have brain damage from lack of oxygen. Unknown time. I'm just looking for answers and hope so we can make the right choices for him. Thank you so much for all the helpful information from Heather. Thank you, Heather, for sending me that detailed email. So, Heather, you know, it's interesting to me how many people I'm talking to every week who says, oh, they told me my loved one is brain dead. And then when they do the brain death testing, they're finding they're not, you know. So again, is that pushing into our topic today where they want to withdraw treatment, you know, and trying to plead a case for it, but testing for brain death test. Now, clearly, the ICU's judgment here was wrong. Your brother, your baby brother, is not brain dead. And if anything, he's waking up, right? So you should hold on to that he's waking up and that there's room for improvement, you know? So never give up hope. You know, clearly he's beaten the odds so far, you know? So the answers that you're looking for is keep going, get him mobilized, get him off the ventilator, get the trach removed ideally. You know, that is what the goal is here, you know, and get him to neurological rehabilitation, right, as quickly as possible, you know. So clearly your baby brother seems to be there. He's clearly showing that. Don't let anyone convince you otherwise, right? So just had an email yesterday, and I have done another quick tip about that, where another lady writes in, she was meant to be, they thought she was brain dead. They did the testing, she didn't turn out as brain dead, and she writes an email now, right? You have to do your own research, and, you know, you have to not give up. All right. So I hope that answers your question, Heather. Leo, I'll get you in now. There you are. Hi, Leo, can you hear me?
Hello, Patrick. How are you? Thank you for allowing me to be on your show again.
It's a great pleasure.
I thank you very much. I should say, myself and my father had a very traumatic last 24 hours. Before I get into that, I can tell you that the beginning of this week, the ICU doctor said that my father, the ICU doctor doesn't see my father getting off of the ventilator in his life. He had to repeatedly last week give him multiple bronchs, and they actually drained fluid off of his right and left lung last week. He said that there is no, if you remember, I'm currently in Florida. Our home is in New York. So he said to me on Monday that he doesn't see that my father is eligible to even take an air ambulance. He's in a critical state. He has to remain in the ICU, and that was on Monday. We had a meeting on Wednesday, and he said my father, the cultures at that time still didn't grow out, and as we speak, the culture results are still not in from the fluid that they got off of him. But the doctor said, let me try using some sort of steroid that I put in a nebulizer to see if that will help him manage his secretions. So I believe it's albuterol that he put into his breathing treatments.
Yeah.
So Thursday, we were supposed to have the family meeting, waiting all day for this family meeting with myself and the case manager and the doctors. Never occurred. Friday morning, I've been living more or less in my father's room with him in the ICU for the time that I've been here in Florida with him. So 6 o'clock in the morning, my father was about 36 hours off of the ventilator. I woke up and I see them removing the ventilator out of the room. Later day into the afternoon, see somebody outside the room, don't know what's going on. We weren't officially assigned a nurse that day. So this is yesterday. Fast forward a little later in the day, a doctor from, I guess, one of the other floors said, I'm going to be taking care of your, I've just taken over your care of your father. Your father has been deemed no longer ICU worthy or eligible because he's been off the ventilator. And I said, what is the steps going forward? He says, I can't tell you that now. I said, where are we going? Are we going to a PCU? What department are we going to? Can't tell you that now. So I've been in a state of angst. I open up an email and it's from the case manager. She says that they found a number of LTACs in New Jersey. So I was a little confused. She says in the email that I have to choose from one of these and I have to answer as soon as possible, not knowing exactly what's going to transpire. So what ended up happening was late last night, we were essentially kicked out of the ICU, brought down to, I don't even know if this is a PCU, what department this is, but this resembles very much an LTAC in decor and the way that the people handle themselves. Haven't seen a doctor. I've interacted with the morning, and now I'm going to be interacting with the evening person, but I'm at my wit's end what to do. So you were just mentioning about never go into a meeting without knowing the agenda. You mentioning um, your your service about ICU at home. So I'm at the point where I'm thinking about maybe actually contracting an air ambulance or some service, signing them out against Doctor AMA, and just bringing him back north and possibly either having I don't know. My father's in a vegetative state. I don't know if he's going to get out of that and to go back to his state after he had his anoxic brain injury and he was mouthing words and simple things. I don't know what his status is in terms of that. I don't know how to get a second opinion outside because I don't know this. I'm not familiar with this area around me. This is I initially came down to Florida to go to Mayo for a second opinion for my father. So I'm not familiar with the surroundings here, and I don't know how I would discern one person from another for their ethics, just by their name, you know. So my thought process right now is sign them out against doctor's wishes, bring them north, and I don't know if it would make sense to do home hospice, home ICU at the home, or bring them to my local ICU. But I've tried when I was at Mayo Clinic trying to do a lateral transfer, a lateral transfer from Mayo Clinic to New York, and they said at that time that I can't do that because it's most ICUs don't take family requests to transfer into an ICU. It has to be recommended by an internist, a doctor of an ICU, in order to admit you. And so I don't have the ability to see somebody out of that nature. So I don't mean to keep, coming on live and taking up all your valuable time, but I'm at my wit's end and I'm looking for your guidance once again. What's all my next steps I should take?
Leo, from what I can see now is there have been some positives. The positives
Yes.
are that your dad is off the ventilator.
And also his kidneys are improving somewhat. He's making some urine.
Okay, so those are the positives, right? I mean,
Yes.
clinically there has been progress since we last spoke.
Yes.
That's a good thing, right? The good thing is someone, and now that he's off the ventilator, that makes it easier for him to be moved. Now, I like I mentioned to you before, I don't see a problem with him getting on an air ambulance being flown to New York or New Jersey. I don't see an issue there. I've seen people being flown around on multiple levels of life support. So the notion that he can't be going on an air ambulance, I don't believe for a minute. Okay, so but taking that aside, given that he's been moved out of ICU because he's now no longer ventilator dependent and his kidneys are improving, well, that's good news overall, given where you were at, when you last spoke to me here.
That was actually last weekend.
That was last weekend. Okay, great. So now, what is more important for you right now? Is it more important for you to get back home as quickly as possible with your dad? Or is it more important for you to stay where you are? Which one is more important?
I feel to get back to New York because, as I've been saying, I've been in Florida now for almost 5 months. I don't have a support network. It's just myself, and I need to have some sort of respite myself. As I'm speaking with you, I feel like I have a fever. I don't feel very well. I haven't slept in the last 24 hours. When I do sleep, it's very minimal. I was in the ICU, so, I'm up constantly listening for if he has any issues because he was having lots of issues with secretions.
No, you need to look after yourself. I think you are at the best point right now to get back home. So whilst I'm very, very much objecting going to LTAC, as you're aware, I do believe if there is a bed in LTAC and for you going back with your dad, this is a window of opportunity that you should take.
Okay.
Right? I really think. And where is he now? He is in a step down ICU. Where is he right now?
He is. I don't know what this department would be called, but I would probably say a PCU. I don't know exactly.
Yeah. Do you think he's in good hands?
Is he in good hands? I don't know because I haven't met a doctor today. I was anticipating, so I would find out what is their plan of their what are the steps going forward. I have no idea. I haven't interacted aside with the day nurse. I haven't, and last night's evening nurse. I haven't interacted with anybody of a medical state, so I don't know what what are the next steps forward. As I mentioned earlier, I got an email from the case manager that she listed some LTACs in New Jersey that are willing to accept him. All I have to do is select one of them. But I feel that if I choose a LTAC, that might be his demise because he's been so infectious. Every so often when there is that recovery, he immediately gets an infection and then he steps a number of steps back. He goes to a lower plateau. He gets weaker and weaker.
Yeah, I hear you. I hear you loud and clearly. But I'm also hearing you that you are not sleeping, and you are not feeling great. You need to look after yourself. You are the most important person here.
I'm sorry, I can't hear you very well.
Okay. I said, you are the most important person here. And if you are running out of steam, no one's going to win. Can you hear me?
It must be my connection because I don't hear you.
Okay, I can hear you. I can hear you loud and clearly. I strongly recommend that you take this window of opportunity and you go back to New Jersey. You are the most important person here. You can't carry on like this.
I'm sorry?
I said you should take that opportunity and go back to New Jersey.
I'm gonna try to move into the bathroom. Maybe that might better the reception. I'm sorry.
Yeah. Yeah.
Okay, I'm sorry.
Can you hear me now?
Very slightly.
Leo, I said you need to go back to New Jersey. You need to take that opportunity because you are the most important person in this. Nothing's going to happen without you.
Thank you.
You need to take that window of opportunity.
Okay. Do you have any other recommendations, like what steps I should do before? Yeah, I know you also had a video recently about discharge. Is there anything that I need to request before we get discharged that I may not be thinking about?
There is a video, Leo, that I just posted recently. I just need to quickly look it up, where I talk about what questions you should ask when going to LTAC. Can you see that? I'm just quickly looking back through my videos. Yeah, so there is a video that I made a couple of weeks ago. 10 questions you need to ask when ICU asks your loved one to go to LTAC. Look at that video.
I will look for it.
Right, it's on the YouTube channel. It's probably not on the website yet, but have a look on the YouTube channel.
I'm so appreciative of all your counsel and your help and your wise words.
It's a great pleasure. It's a great pleasure. It's now your turn to look after yourself. You need to go back home.
Thank you very much. God bless you, Patrick. Thank you for all you do.
It's a great pleasure. It's a great pleasure. All the best to you and your dad, Leo.
Thank you, Patrick.
Thank you. Thank you. All right. So let's wrap this up for today. I will do another YouTube live again next week around the same time. I will also talk to you during the week in my quick tip videos. You know, because we get so many questions, we have also created a membership for families of critically ill patients in intensive care at intensivecarehotline.com. If you click on the membership link there, you can get access to it, or you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email. And we answer all questions intensive care related in there. I also offer one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly. You know, if you have any family meetings with them, I will be there. I also have you strategize before a family meeting whether going there is the right thing to do in the first place. And I make sure you make informed decisions. You have peace of mind, control, power, and influence. And furthermore, you need to and I ask all the questions to the doctors and nurses that you haven't even considered asking, but must be asked in situations like that. Also, before I forget about it, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the videos with your friends and families, and comment here what you want to see next, what questions and insights you have. Also, we offer medical record reviews in real time so that you can get a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. And like I said, we also offer intensive care at home, and you get more information at intensivecareathome.com. With intensive care at home, we are providing a genuine alternative to a long-term stay in intensive care, and we send intensive care nurses into the home for predominantly long-term ventilated adults and children, but also adults and children that are not ventilator dependent but have a tracheostomy, clients that are not having a tracheostomy but are BiPAP, CPAP ventilated, seizure management, home TPN, home IV potassium infusions, home IV magnesium infusions, port management, central line management, peak line management, Hickman's line management, as well as palliative care. We are also sending our critical care nurses into the home to keep them out of ED, out of emergency department. If you're a hospital looking for that, how to keep your ED empty and bypassing the ED in the first place, we want to hear from you. With intensive care at home, we are currently operating all around Australia in all major capital cities, including regional and rural areas. We are an NDIS approved service provider all around Australia. We are a TAC approved service provider, a iCare approved service provider in New South Wales, NIISQ in Queensland, as well as DVA approved Department of Veteran Affairs all around Australia. We also have received funding through public hospitals, departments of health, as well as private health funds. We also provide level 2 and level 3 NDIS support coordination. We also provide NDIS nursing assessments. And contrary to popular belief, the NDIS is actually funding nursing care, just needs to go through the right advocacy process, which we are the experts in. And lastly, if you are in the US or in the UK and you are interested in intensive care at home, we can help you there privately. Please reach out to us at intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. And once again, thanks for watching. If you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days and during the week. Take care for now.